So when someone comes in to see me, right, for an eval, you know, when we first come in and do an eval, so they'll come in and say, so their manager is going to be is it okay if we transition? I'm so aware that we don't have a lot of time, and I feel like I'm flying through all of this and leaving lots out, but so we're just giving you an overview. So I want to give you just sort of a quickie of how we would work with someone. And I don't have this one on PowerPoint. So what happens is usually someone comes in because they want to appease somebody that's upset with them. They've had a medical emergency, and now they're freaked out and scared. So they want to do something about that. A part of them, a critic, took over and said, we're never doing that again. You know, we're never doing that behavior again. So they come in, often looking fairly, you know, except for teenagers, because sometimes their parents made them come in, but they come in anyway. So they come in, well, that's still appeasing. So they come in for some reason like that. They certainly don't come in to stop their addictive behavior. They tell you that's what they've come in for, but this part has not agreed to that, okay? So they come in and we do an eval. This is great. I love your facility. You're the perfect therapist. I'm going to tell all my friends about you, and et cetera, et cetera. And, you know, and maybe they just got discharged from a program somewhere. So I'll say to them, so that's great. I'm really excited that a part of you really wants to be here. I really hear that a part of you really wants to get better. But tell me what your eating disorder or your cocaine using part of you is saying about that. Well, then you get this pause, because no one's ever asked them that question before. And you get a really interesting answer. You know, I don't want to be here. Well, we'll be here for today, but we're going to do what we want over the weekend, et cetera, et cetera. I've also asked when they've come out of, you know, they've come out of programs like an IOP or a PHP or an inpatient, I'll say, so, or residential. So what was your eating disorder or what was your drug using part saying about you being in that program? No one ever asked them that question either. So they'll look at me like, whoa. And they'll say, well, that part was saying that we'll just gain enough weight to get out, you know. Or that part was saying that, well, we're not going to do heroin anymore, but we're going to smoke a little weed. So now I'm beginning to get a sense of what's going on in their addictive system, right? So I'll say to them, well, it sounds like you have sort of mixed feelings about being here. So what would it be like if we work with both of those parts of you? Okay? And they'll be like, yeah, that would be good. And I'll say, well, we don't have to change anything right now. We're just going to kind of get to know what's going on with you inside. And there's a sense of relief, you know. And then I'll say, so tell me a little bit more about what you would like to work on here right now. So even if they said, I want to work on my marriage problems, and I know they have a terrible addiction, all roads lead to Rome. So I work collaboratively with this client. You know, eventually I'm going to be able to weave back in how these parts are impairing their relationship with their spouse or their partner. So I start working with we call this the protective system. I didn't make that clear before. So this is the protective system, and this is what we usually see with folks, right? Now, which side do you think that as therapists we're usually on? That side. And what side is the family members usually on? Often they're on this side, sometimes they're on this side. So, so often the family members are on this side, especially with young folks that come in. Sometimes the family members are on this side, because if, you know, so-and-so gets clean, I might have to like own that I have a problem. So let's just keep focusing on their stuff and sabotaging it, because that way I don't have to own my stuff. Like a really common thing I see when I work with folks, with my eating disorder folks, a lot of folks are married to sex addicts. This is really interesting because they're so busy with their eating disorder, they're kind of often sexually anorexic, and then the other person can do whatever they want to do, or they're drinking or whatever. So they're co-signing for each other's addictions. So that's the reason why you might want to get people in the family involved in treatment, because you want to see what's going on there. So sometimes they'll be allied with that. But either way, you know, we're going to be allied with some aspect of the protective system, because nobody wants to go here, right? Even as a therapist, I might say, I just don't think I want to go down to that dark space. You know, you might not even be like mentally aware of it, but there might be something about that you're doing that makes you not want to go there. So we're working with this. So my first step with addictions, which is different than when we work with regular populations, I really have to spend a lot of time with this protective system. All right, with people that don't have addictions and such, often we can get this kind of stuff to relax, and we can work with, the exile stuff. But this is the work, and I became a really good negotiator. Before I was a therapist, I used to work for a Fortune 100 company, and I used to be a senior marketing rep for them, and and I learned how to negotiate and stuff. So those negotiation skills have come in very handy. So rather than kicking this part out the door, I befriend the part, kind of like we just did before, and we begin to negotiate. So, what would your drinking part be willing to do? Your life is really screwed up now. It sounds like, what would it be willing to do? It would be willing to try an AA meeting. Great. So why don't you go to the AA meeting, and when you come out, we'll talk about how that was, Would it be willing to quit drinking or not? No, it doesn't want to quit drinking, but it'll go to the AA meeting. Okay, so we won't quit drinking yet. So then they come back in, and we start working on, parts that were up around the AA meeting, and eventually get them to, whatever they need. Now, if people are really far gone, I'm not going to be able to show you how to do this. I'll start to do more work about how this part is, not accomplishing what it wants to do. So when we checked in, the part, whatever it said to you, had some function, some protective function, correct? So let's say its intention was to relieve anxiety. Well, we'll begin to work with this part to show it, to get it to agree that it's not successful. I ask it, so on a scale of 1 to 10, ask this part how successful it's been in your life in relieving your anxiety at this point. They never say 10. Well, it's an 8 or 9. Well, why didn't you say 10? Well, because I have, the shakes in the morning. I have to go to the psychiatrist and get tranquilizers because I'm so nervous, et cetera, et cetera. So, so then I'll say, so if you could find another way to relieve your anxiety, check in with that part and see if it would be interested in it. Well, no, because you might try to get rid of me. Well, no, we're not going to get rid of you. Is there something else that part would like to do for you? If it didn't have to get you drunk every night. Well, yeah, would like to take trips to Europe or something like that, or plan trips. Great. Okay. So that's kind of how we do it. But it's not as simple as I do it one time and it happens. You have to have patience working with people with addictions. So we keep going back and forth, working with the protective system until there's an agreement for this part to relax, and you get some level of sobriety or recovery, and then we can start doing, work with this stuff to prevent relapse. So that's kind of how I work with it, And it can and it sounds simple, but it's not like they come in and I do it one time and they're all set and ready to roll. I have to keep working with them and working with my parts and being present with them. And there are times where, if I need to, through a more compassionate way, I will voice concerns and needs to, do other things besides what we're doing. So I don't just have someone coming for 50 years and keep doing it and we don't do anything else. But that's essentially how we work, which is really different because most of our theories are aimed at getting rid of this and sort of maintaining that. And then hopefully, if you get into 12 steps, you might do some of this work too. And so that's essentially a quickie of how we work.